Hello everybody, so I'm doing this study with Dr. Val Cheever, and this is the comparison of minimally invasive treatment modalities for post-orthodontic white spot lesions, and we're going to be looking at tooth bleaching, microabrasion, and resin infiltration. So orthodontic treatment is commonly sought after to correct malocclusions and achieve optimal alignment, and thereby improving patient aesthetics. One of the big side effects from orthodontic treatment, especially with fixed appliances, are white spot lesions. These are areas where plaque is accumulated, and that eventually leads to demineralization if the patient hasn't been keeping up with proper oral hygiene. Approximately 50% of people in fixed appliances will develop at least one white spot lesion over the course of treatment. The visual change from white spot lesions is due to the air present and the subsurface porosities causing different refractive indices. The goal of this research is to provide a comprehensive comparative analysis of those minimally invasive treatment modalities for white spot lesions after orthodontic treatment. The treatments compared in the study include tooth bleaching, microabrasion, and resin infiltration, and we'll also explore remineralization therapies to be used in conjunction with those treatment modalities. So here I'm just going to go over the gist of the method of action of these treatment modalities. So with tooth bleaching, it uses high-strength hydrogen peroxide gel, usually anywhere from about 35% to 40%, and that'll produce free radicals that break down the pigmented molecules that cause discoloration in teeth. As for microabrasion, the goal is to mechanically abrade the surface layer of the enamel using an acidic or abrasive paste in a prophy cup. And resin infiltration, you'll use a 15% hydrochloric acid, which you'll apply to enamel, you'll dry it, and then you'll apply a resin infiltrate to hopefully occlude the microporosities that you expose. And then the fluoride and the CPACP, or amorphous calcium phosphate, those are the remineralizing agents to help gain tooth structure back. As for our methods, we just did a thorough literature search through the numerous databases, including PubMed, Google Scholar, Scopus, and the Cochrane Library. Some of our inclusion criteria were publications in peer-reviewed journals, make sure it's written in English, involvement of human subjects with white spot lesions regardless of age or gender, evaluation of minimally invasive treatment options, including but not limited to microabrasion, bleaching, and infiltration, and comparative studies, our randomized control trials, cohort studies, case control studies, and systemic reviews were primarily used. Some of our exclusion criteria were if they're conducted on animal models like extracted animal teeth, if they weren't written in English, were not published in peer-reviewed journals, focused solely on non-minimally invasive treatments, so like composite restorations or veneers, crowns, other full or partial coverage restorations, or they did not include relevant outcomes. We found 21 articles to evaluate in this study. For studies that were looking at resin infiltration, there was one that was a randomized controlled study, 2 were clinical trials, 2 were case studies, and there was 1 in vitro experiment. The microabrasion category had 1 standalone RCT but was compared to other modalities in the included articles. There is a lot more literature on the effects of remineralizing agents, and we found 2 RCTs, 1 clinical trial, and 2 in vitro studies. There were few articles that discussed the use of lasers, but there were 2 in vitro studies that were found. There were some other articles that also just kind of made comparisons between the multiple treatment modalities discussed in this paper. So for resin infiltration, just a quick overview of how it works. It involves applying 15% hydrochloric acid to the white spot lesion, and then that is dried, and then that is followed by a TEG DMA infiltrant, just like a flowable resin essentially, that's applied to the lesion and then cured. Abbas et al. Split the lesions into 4 groups, so a shallow enamel lesion, a lesion into the deep enamel, the shallow dentin, and deep dentin. They found that with 1 etching and then 2 applications of resin infiltration, all lesions were masked until deep dentin, where it was still visible. So it seems like it works up to shallow dentin really well. Many of the other studies only had up to a year follow-up post resin infiltration treatment, but Cazzola et al. also displayed that it is successful up to 4 years and possibly even beyond. Overall, we found that it seems to be the best and most stable treatment option for masking white spot lesions. Prescribed tooth microabrasion, it is basically carried out by applying 15 to 18% hydrochloric acid to the lesion, so kind of similar first step to resin infiltration, but then an abrasive pumice is utilized in a prophy cup to actually remove some of that affected enamel, and the acid helps to remove that exposed enamel. Gu et al. Showed that microabrasion initially reduced the lesion size by about 17%, and then some further resolution was observed over time. It seems that this is due to the removal of the surface layer, further encouraging remineralization of the deeper lesion areas. So a potential advantage to microabrasion is that you can use it in conjunction with dentifrices, so toothpaste and stuff like that with fluoride or CPP, ACP, and that after the microabrasion wears away that surface layer, the inner layers are exposed, creating more ability to remineralize. So 2 of the most common remineralizing agents that were studied were CPP, ACP, or casein phosphopeptide amorphous calcium phosphate, and then they also kind of looked at different concentrations of fluoride. Overall, the current literature points to a limited ability to mask the lesions fully through remineralization, just because it can't really penetrate too deeply. Oliveira et al. Found that 1.1% NAF dentifrice was superior to MI paste in remineralizing white spot lesions, and other studies have also concluded that the concentration of fluoride in regular toothpaste is effective enough. A high dose of fluoride actually physically blocks the surface layer of enamel, so the ions can't really get to the subsurface layers. So it's actually better to have a high dose of fluoride for inhibiting lesion formation, so before and during braces, and then a lower dose utilized for remineralization and controlling lesion progression. So laser therapy hasn't been too well studied yet, but in one study they used an ER-YAG laser, and that kind of changed the chemical composition of the enamel to increase permeability of fluoride ions. This encouraged the uptake of fluoride in deeper portions of the lesion, leading to increased formation of fluorapatite crystals, thus hardening the inner layers of the tooth. There's another study that uses CO2 laser along with fluoride varnish, and they found that applying fluoride prior to laser treatment actually yields a better result and protects against the undesirable effects of the laser alone, which you can see in the second column of this picture here. And then not only is the appearance of the lesions affected, the lasers also actually increase the micro-hardness of enamel, so possibly protecting it from future demineralization.